All right. We're going to dive right into our next session. And the day is really organized around several sessions, as I mentioned earlier, to look at the different missions, the different bodies of work that we do here in the Division of Palliative Medicine at UCSF. And we're going to start this morning with innovation and research. And we're going to hear from three teams doing work in this area. And we're going to start with the Pro-PC team. And I'm delighted to invite up Laura Schoenherr and Joanna Sharpless. Yuika Godo's part of the team, but she is not here today. She's away, but delighted to have you come on up.
Thank you. As Steve mentioned, my name is Laura Schoenherr, and together with Joanna Sharpless, on behalf of our full team, we're excited to tell you more about the Pro-PC project, which stands for Proactive Palliative Care in the Inpatient Setting. So in short, the goal of this project is to expand the reach and equitable delivery of palliative care by developing a system to proactively screen hospitalized patients for palliative care needs and deliver innovative interventions to target the unmet needs. Put another way, we want to transition from the current system where we receive patients by reactive referral to a standardized proactive approach, because we hypothesize that the current system is actually missing a number of patients who have palliative care needs. And it's also potentially contributing to disparities in access as a result of unconscious bias on the part of people who are referring. We've already made great headway in this work, and so I'm going to go through some of our main accomplishments to date. As a first step, we developed an electronic screen to identify admitted patients with serious illness who might be candidates for palliative care interventions if they were found to have a need. We subsequently developed a set of criteria to identify which of those patients have palliative care needs that we could potentially address. And then to make sure that we were capturing as full a picture as possible of the palliative care needs in the electronic screens that I've mentioned above, we then conducted a survey by phone of all patients at UCSF, of their bedside nurses and their primary providers, and compared the results of our phone survey to the electronic screens. We used the results of our survey to improve our electronic screening criteria and to hone in on those that were most helpful in identifying a true palliative care need. And then finally, we applied weighting to those criteria so that they could be used to generate a composite need score to rank each patient by their acuity of need. So here you can see our final serious illness algorithm, which flags patients as having serious illness if they're on a primary team that's thought to be indicative, of having serious illness, such as advanced heart failure, liver transplant, malignant hematology. If they've spent more than 48 hours in the ICU, if they have an ICD-10 code assigned to them that indicates that they might have serious illness, if the word metastatic is present in a progress note, or if they're over the age of 75 and have had at least one hospitalization in the past year. And then as compared to a gold standard of expert consensus of our study team, the final algorithm was found to perform quite well with a sensitivity of 89%, specificity of 82%, a positive predictive value of 80%, and a negative predictive value of 90%. So once we finalized our serious illness screen, we then turned our attention to the development of criteria to identify palliative care needs within that subpopulation. To do so, we first convened interdisciplinary work groups, and many members of those work groups are actually here today, so thank you. And they used a combination of literature review and clinical experience to develop an initial set of 76 criteria to identify palliative care needs across 5 domains: advanced care planning, caregiver distress, physical distress, psychosocial distress, and spiritual distress. We then validated those initial criteria through a modified Delphi process, and ultimately 56 criteria emerged from that. 40 of the criteria were based on data contained within the EMR, and 16 required a clinician interview. We used these criteria to screen all patients with serious illness who were hospitalized at UCSF in September 2021, in a survey that you'll hear more about from Joanna in a moment. And then the work groups, as I mentioned, used the survey's results to identify the 28 EMR-based criteria that correlated best with palliative care need, and then developed that weighting system to generate a 0 to 100 composite need score. Finally, we validated our score against a gold standard of primary clinician assessment of unmet palliative care need from that 2021 survey. And just to give you a sense of what we mean by these criteria, here are some examples. For example, Patients were flagged as having an advanced care planning need if they did not have an advanced care planning note in their chart after a prolonged length of stay. We also used the presence of a PCA other than in postoperative patients as a proxy for identifying patients with severe pain. We also looked at progress notes that had words such as imminently dying, comfort care, or hospice as a proxy for end-of-life care planning needs. And then progress notes with words like hope for a miracle, God, or praying as a proxy for need for spiritual care support or religious advocacy and goals of care conversations. We performed a number of analyses to evaluate the performance of our screening tools and found by several measures that they perform well. So for example, a higher need score was associated with an existing palliative care referral. That is, patients who were already followed by our inpatient palliative care team were more likely to have a higher score and vice versa. And then additionally, a higher need score was associated with that unmet palliative care need as reported by the patient's primary provider or bedside nurse. We used a receiver operator characteristic curve analysis, and that resulted in an area under the curve in the acceptable range of 0.6 to 0.7, depending on which clinician was reporting the unmet need. And then after validating our screening tools, we finalized both of our algorithms, and now we receive a daily report that lists every hospitalized patient at UCSF who was identified as having serious illness, and then lists their composite need score on that day.
As Laura mentioned, one of the really ambitious things we did in this project was to conduct a large survey of providers of admitted patients with serious illness. And part of the purpose of this was to validate and improve our screening tool, but our other goal is to create a day in the life snapshot of the prevalence and quality of palliative care needs of our inpatient population. And that would additionally allow us to help advocate for resources to meet the true amount of palliative care need that exists. Our hypothesis, as you've heard, was that the true need was much larger than the patients referred to our team, and this was one of the ways that we went about capturing that. In order to do this, over 1 week in fall 2021, we ran the screen on the hospitalized patient population every morning and then conducted a phone interview of both the bedside nurse and the primary provider for each patient. The survey showed that about half of all hospitalized patients screened in as having a serious illness, and we were actually able to reach the nurse or the primary provider for 224 or 84% of patients with serious illness. Guys, it was a lot of phone calls. Come on, 84%? Pretty good, right? Of those we were able to survey, 27% were reported to have unmet palliative care needs, and about a third had uncontrolled symptoms and or non-physical suffering. But only 7.6% of patients with serious illness were receiving inpatient specialty palliative care. So this proved our hypothesis to be correct and showed us that the bottom line is that our current referral-based consult system is missing many patients with palliative care needs, and therefore we must develop new strategies to meet this need. We are so excited now to be putting our new tools into action by piloting a program at Mission Bay to actually see patients who screen in as having high palliative care needs. We have a few goals as a part of this pilot program, including assessing the feasibility of putting the screen into action, comparing our patients' needs in real life to what the screen indicates their needs are, contrasting characteristics and needs of patients in the ProPC pilot with patients who are referred through the standard system, and measuring and comparing outcomes for ProPC patients. In order to achieve these goals, a palliative care physician evaluates the chart of 1 to 2 patients at Mission Bay with the highest score each week and contacts the primary team for permission to see the patient. And then the physician and or the social worker and chaplain see the patient and fill out a survey with feedback on the patient's palliative care needs. We also plan further data analysis on the mountain of data that we've already gathered. First, we're conducting a retrospective analysis that runs the screen on all hospitalized patients in the past year and compares outcomes of patients with low, medium, and high need scores. Second, we're conducting an equity analysis to compare patient demographics across the following subpopulations, which may identify disparities and or bias affecting access to palliative care. We're also turning our focus from developing the screening tools to disseminating our accomplishments and findings which we think are also applicable at other medical centers as well. We have presented on this project several times at our national conference, AHPM, and have several manuscripts underway and planned. There are, of course, many opportunities and questions that remain for both the present and the future with this work. First, we are always thinking about ways to continue to improve our screening algorithms, particularly given the imperfect nature of information captured by the EMR. And with the increasing focus on AI, we do wonder if there's a role for more advanced machine learning and AI in future iterations of the screening tools. We're also working to develop interventions to meet unmet palliative care needs, such as standardized order sets, triggered chaplain or social work consults, and e-consults for symptom management, among other ideas. And as always, importantly, we're working to advocate for more resources to meet the additional needs that really have been proven and shown by our work. We're extremely excited to see where this work takes us next, with the hope and intention that it will be able to extend all of our reach to patients who are not currently touching, who need us. We want to thank you for your attention, and we welcome your feedback and ideas throughout the remainder of the day today.